Thanks, Alicia, and good evening, everyone. It's a pleasure to have been asked to speak to you all again, and as Brightcore for us to be able to kind of sponsor this series. One of our kind of key areas of focus as an organisation is to provide high quality, low cost support and training to the 1100 schools and colleges that we work with now nationally. So yeah, part of our mission is to be able to do things like this. So it's great to be able to have this opportunity to talk to you all and to provide an update around where we are from a mental health and education perspective this year. So I'll without further ado share the slides, and hopefully you can all now see my screen. And if everybody else is in front of the PowerPoint slides, as it were, from your point of view, if you use the View Options tab in the top right-hand corner of your screen, one of the options you can click on is side-by-side setting, just to move everybody out of the way. If you click side-by-side gallery or speaker view, then it stops the pictures of everyone else being in front of the screen. So if I start by looking at where we are I suppose from a safeguarding point of view, first and foremost, as is always the case in pretty much every education setting, we start with safeguarding, and it's half of where we work as an organisation, as I know some of you know. So when we look at the many facets of safeguarding and promoting welfare in education, you can see mental health and well-being on the right hand side there is just one of the ever increasing list of areas that we have to consider. It's one of the largest ones, in fact probably the largest one now. When we look at data nationally, we can see that mental health concerns are the largest category that staff are reporting through to DSLs, and there's a real overlap between the work of mental health leads and the work of safeguarding leads. And I know in a lot of schools and colleges it's the same person doing that job, but it's really essential that we look at how these things overlap and how the roles are not necessarily merging, but there's distinct connections between them. And it's really important that we've got effective information sharing in place. So if we think about keeping children safe in education, both Ofsted and ISI, of course, follow keeping children safe in education when it comes to inspection and also safeguarding, because their job is to make sure we are following the statutory guidance that's out there. So when we look at keeping children safe in education, as you will all know, or I hope you all know, the definition of safeguarding changed in the latest version, in the September 24 version. And what you can see on the screen there is the text that is in red was added for September 2024. So we got that whole new bullet point around sort of early help, providing help and support to meet the needs of children as soon as problems emerge. But the text that's highlighted in yellow is where mental health sits from a safeguarding point of view. So we know that first bullet point's looking at that early help response. Absolutely, we want to be trying to intervene early to help when we're identifying possible mental health concerns. But also linked to that middle bullet point, preventing the impairment of children's mental as well as physical health and development, is a safeguarding responsibility. So, as I said before, there is a clear overlap between the role of the senior mental health lead and the safeguarding lead, just from that bullet point in the definition of safeguarding alone. And then finally, that final bullet point, taking action to enable all children to have the best outcomes. We know that sort of proactive approach is going to be essential when it comes to putting in effective whole school approaches to mental health and well-being. So we know from an inspection point of view, mental health is going to sit partly under safeguarding as well. If we look within keeping children safe in education, and we look at part one, the bit that all of your colleagues who've got access to children should have read and understood, we look at how mental health sits within there. We've got, first of all, paragraph 43 from a safeguarding point of view, and paragraph 44 as well from a safeguarding point of view, that both reference safeguarding. Paragraph 43 talks about all staff being aware that mental health problems can be an indicator of abuse, neglect, or exploitation in children. And we do see a correlation. It's roughly about a third of cases of mental illness in children seem to be linked to safeguarding or child protection incidents that we may or may not know about. So it's really important that we're aware as education leaders, and if you're the senior mental health lead or the safeguarding lead, that if staff are spotting a mental health concern, there may well be a safeguarding child protection concern going on that we don't know about yet. So that professional curiosity is essential. But equally, the reverse applies. If you've got children with safeguarding and child protection concerns going on, statistically, they're going to be at higher risk when it comes to mental illness. So what do we do to try and prevent that is a key question. Then paragraph 44, the next one, you've got only appropriately trained professionals should attempt to make a diagnosis of a mental health problem. I think we'd all agree with that one. I know a lot of education settings might have the odd member of staff who's clinically trained, but most education staff are not clinical specialists. And so therefore, even if we've done things like mental health first aid courses and so on, or we've got a mental health lead training under our belt, we need to stay away from the diagnosis. It takes clinical professionals a few months to diagnose things effectively in a lot of cases. So I think we'd all agree we'll leave that to clinical professionals, but it's that next sentence that's the training requirement. Education staff, however, are well placed to observe children day to day and to identify those whose behaviour suggests that they may be experiencing a mental health problem or be at risk of one. So that's the thing that we need to focus on with our colleagues, making sure they're confident around what to spot and how to report it, and focusing on behaviours rather than sort of clinical symptoms. We do a lot of friendly pairs of eyes reviews for safeguarding and for mental health and wellbeing, as some of you know, because I know we've done some with some of the schools of those of you who signed up for this webinar this evening. And when we speak to members of staff as part of those reviews, this tends to be the area that a lot of staff talk to us about in terms of not feeling that confident or 100% sure exactly what to spot and how to report it. And actually, it's the same when it comes to the early help section, which is a little bit earlier on, actually, in part 1. Paragraph 18 talks about all school and college staff being particularly alert to the potential need for early help for a child who's got a mental health need. So again, they need to know what to spot and how to report it to be able to respond to that effectively. If we look a little bit later on or further on in keeping children safe, if we look at part 2, the management of safeguarding, where it covers the responsibility of governing bodies, proprietors, management committees, and so on. Paragraph 184 talks about the fact that, again, this might be an indicator, mental health concerns might be an indicator of abuse, neglect, or exploitation. But then it says very clearly that governors and proprietors should ensure there are systems and processes in place for identifying mental health problems, how to escalate, how to refer, and so on. So it is a strategic leadership responsibility of the governing body and the proprietors to make sure you've got systems in place to identify and respond to mental health concerns. And the key recommendation from the DfE is that all schools and colleges appoint a senior mental health lead and designate a senior mental health lead. Now, the DfE is very clear to say at the moment, this is still not a mandatory position. It's just highly recommended. But they would expect that senior mental health lead to be a member of the senior leadership team or be closely supported by a member of the senior leadership team to be able to fulfill that role and execute it effectively. So where are we? Are we seeing an increase in mental health problems? I know I touched on this topic last year. I'm sure the majority of you would say yes. Some of you might say no, of course. The yes arguments are always revolving around, well, just look at what we're dealing with, look at what's covered in the media, look at the number of cases and so on we're seeing in schools. The no arguments usually revolve around the fact that we're talking about things that 30, 40, 50 years ago we didn't talk about. So therefore, we're recognizing and responding to things that historically weren't on our radar. The no arguments also revolve around the sort of prevalence inflation hypothesis, which is basically the more you look for something, the more you're going to find it. And of course, we are all looking for it now, particularly when we've got senior mental health leads and a focus on it as well. We've also got to be careful not to over pathologize and not to find things that aren't necessarily there. A colleague of mine who works for CAMS gave me this slide. If you look at the features of emerging mental health disorders in young people, those are the top 10 features that you can see on the screen there. If we then, I won't read them out, I'll let you have a look at them, but if we then look at the features of adolescence, the top 10 features of adolescence, there you go, it's the same 10 really. So we've got to be careful not to over pathologize. We've got to be careful not to spot things. And we do see quite a lot of parents, perhaps as well as young people, diagnosing their children with anxiety disorders when they mean worry or they mean natural anxiety. It's perfectly natural to experience anxiety. We know it's an evolutionary mechanism designed to save your life. So we go into any school or college in the country at this time of year, it is perfectly natural to see children with symptoms of anxiety. When you think about examinations, sleepless nights, pacing around, butterflies in the stomach, it's a natural experience because there's a reason they should be experiencing anxiety in a lot of cases. That doesn't mean they've got an anxiety disorder. Now, if that's still there, those symptoms are all still there in middle of August, then perhaps. But we've got to be careful, as I said, not to kind of over pathologize. And that's an area that we do have to work extensively in and work to support parents as well. But if we look at the recent data sets over the last few years, we can see actually the answer is probably yes. We are seeing an increase in concerns. So if we look at the pre-COVID study, that was published in November 2018, looking at the calendar year 2018, that data from the NHS showed that 1 in 8 young people of school and sixth form age, it was 1 in 9 if we just look at school age, had at least one mental disorder when assessed in 2017, and 1 in 20 met the criteria for 2 diagnoses. So we'd seen an increase. This was an increase on the previous NHS study, which was 2004-05 that year. That showed 1 in 10 children. So we'd had that over 20% increase pre-COVID. And then, of course, since COVID, things have significantly deteriorated, or the numbers have increased, depending on which way you want to look at it. So the wave 1 follow-up that the NHS did in 2020, in summer of 2020, showed, you can see with the red columns or the red bars being added on there, we saw a significant increase in mental health concerns of both boys and girls of school age. And the numbers basically went from 1 in 9 in that age group to 1 in 6. We saw the repeated study, the wave 2 follow-up that was done in September 21. You can see the grey columns being added on there, and we saw a slight increase in school age boys and a slight decrease in school age sixth form age girls, but overall those numbers stayed at that sort of 1 in 6 figure. Then the wave 3 follow-up that was done at the end of 2022 showed still that sort of 1 in 6 figure for school age and an increase for sixth form age. And then when we look at the wave 4 follow-up, which is still the latest one done right at the end of 2023 from the NHS digital studies anyway, the data showed we'd seen a further deterioration, an increase in mental health concerns when we look at school age young people and sixth form age young people. So we've got now overall 1 in 5 children and young people have a probable mental disorder. That's 20.3% of school aged children and 23.3% of sixth form age young people. So even if we just look at the NHS digital studies, we know that since 2017, the likelihood of a young person having a mental health problem has gone up by 60% in that sort of 6 to 7 year reporting window, which is a significant increase, and that I'm sure is being reflected in the reality of what you're dealing with in the education settings. I know it is in terms of the ones we support. Then you can also look at the Good Childhood reports, and I mentioned the previous version of this last year. They look at lots of different things. The Children's Society publish these every September, and one of the things they look at is happiness in children in the UK, and you can see yet again we've seen a decrease in happiness in the UK. Now, the eagle-eyed amongst you will notice the data on the right-hand side goes up to 2022. That's because the Good Childhood reports from the Children's Society are really rigorous. It actually takes them about 18 months to analyse the data for each report. So the 24 report only goes up to 22 and so on. But when you look at that particular graph, as you can see there, we've seen a pretty much continual decline in children's happiness in the UK since sort of 2009-10, really. So something is going on, something has changed, and that is the subject of considerable debate. And there's lots of research going on as to possible causation. I know when we look at that sort of time frame, it's easy to say, well, that's when smartphones came onto the mass market, which is kind of true. But when we look at the research, it's not really just screens that are the issue. It's what we're doing or what we're not doing with the screens that seems to be the issue. And I know there's a lot of research going on in this area over the next 12 months or so, and there's a lot been done already. Organisations like the University of Cambridge and so on doing a lot of excellent work in that area. But we are seeing this statistic now, that we're seeing this trend, as it were, in terms of this reduction in happiness. So yeah, the reality is we are seeing increasing concerns. Also, when we look at the figure for the burden of disease, it's quite interesting that it's quite different between physical and mental illness. So if you're not familiar with that term, the burden of disease, that's calculated by putting two specific figures together, looking at the profile for each disease. So the first figure is for each disease, if you look at the number of years of life lost as a result on average of having that disease, that reduction in life expectancy. And then the second figure is the number of years living with a permanent disability as a result of having that disease. When you put those two figures together, you get what's known as the burden of disease. And you can see from the profile there, the burden of disease for mental illness, very different to that of physical illness. So with physical illness, as you might expect, we see this sort of spike in infancy before the immune system's fully developed, and then an increase as the body sort of physically ages and falls apart, as it were. But with mental illness, we see this disproportionate impact and burden in children, young adults, and middle-aged adults before it sort of tails off in older age. Now, that's a problem for several reasons. One of them, of course, the impact on those individuals physically and mentally, of course. So we're all aware of the moral, ethical, medical reasons we should be addressing mental health concerns. But actually, there's also, when you look at this graph, a financial reason why states should be addressing this more than they do, because that's the age of peak productivity. That's the age when not only are we our most active, but also we're our peak level of contribution to society, generating income for the state. So there's a key financial reasons why states should be addressing this. And if we look at some of the data, for example, published by the Centre for Mental Health, you can see their calculation is that mental illness is now costing England £300 billion a year. And just to put that in context, the NHS budget for 2022 was half that, roughly 153 billion. When we look at the estimated impact of COVID, it was 260 billion. So we're costing way more than that. So this is huge figures. We're talking 15% of GDP there. So actually, there's a real reason states need to get a grip of this, and we need to get a grip of this within this country as well. We can see the increase in antidepressant prescriptions as well, reflecting this increase in mental health concerns. So if you look at the rates of antidepressant prescriptions, the number of scripts written, as it were, you can see 9 million in the 1990s up to 86 million at the end of 2023. That's now 8.5 million adults, 192,000 children and young people aged over 10. And then when we look at the profile of sort of peak age of onset in terms of diagnosis when it comes to depression, you can see in the 1990s, the sort of peak age was for men was 50 and women sort of dual peaks around 50 and 75. And yet by the time we got to 2016, we'd seen a real shift to the left there. And actually for males, early 20s, for females, late teens. And so again, just linking that back to a couple of slides ago, when you think about that burden of disease, that long-term impact for a lot of those young people, it's really significant. And of course, that's reflected in what you're dealing with in the education settings, I'm sure. So what's going on? Well, we know that childhood and adolescence is a period of challenge. It's a period of change and transition. And if we look at the key challenges of childhood, there's some quite significant life events in here. And when we think about starting school, transferring from primary or prep to secondary or senior, friendship changes, puberty, exam pressures, family changes, whatever they look like in terms of new siblings, divorce, bereavement, and so on. And then sexual maturation and development. And then transition to university and work. It's huge, huge life events for a lot of young people to go through. But the phrase, as I would say, is "'twas ever thus." We as adults have all been through that list. So we can't just say, well, childhood and adolescence has got more challenging. COVID was an exception. But as the data I've already shown you suggests, we had already seen an increase in concerns pre-COVID. COVID might have exacerbated things, but we can't just put all of this at the door of COVID. So yeah, what's going on? Well, that's an area that we look at extensively in terms of the training we do with all the schools and colleges and looking at the senior mental health leads. And yeah, we can blame technology to a degree, but as I said, it's not necessarily the technology that's the issue. It's what we're doing or what we're not doing with the tech. And there's some amazing technology out there to support mental health, which I'll signpost you to a few examples of a little bit later on. So what can we do as education professionals? There's lots, actually. I think the first thing is make sure we've embedded an effective whole school approach to mental health and wellbeing. Make sure you've got a designated senior mental health lead in place, and that we ensure that mental health and wellbeing education is an effective part of the curriculum and not just a bolt-on token gesture, just a few lessons here and there. Looking at how we truly embed that. And that comes down to things like quality senior mental health lead training, understanding all the resources and approaches and research that's out there. And as part of that, then, as education leaders, whether we're the senior mental health leads or not, improving our knowledge around mental health and wellbeing, looking at how we can identify children and colleagues who need support, looking at and understanding how we can respond effectively as education providers as well as professionals. So when we think about whole school approaches, really we're talking about those 8 main areas: effective leadership, effective oversight. Have we got a document that sort of says this is how we're going to do things in terms of our approach? It doesn't have to be a policy, of course, but it can be a policy, a strategy document, an overview diagram, that kind of thing. Procedures, what do we do to respond, to prevent? That will include interventions, of course. Culture, what's staff knowledge and training like? Are staff confident around what to spot and how to report it? What's the ethos and environment like as part of that as well? Then the curriculum, as I've just been talking about, how do we educate in an age-appropriate way, in an effective way to improve and prevent mental illness? And how do we provide effective student or pupil voice in this area to really engage those young people, and give them opportunities to lead some of the provision as well as respond to us? And then finally, parental engagement. What does that look like? How do we make sure that that enables parents to support their child, to understand and engage and back up what we do as education settings? So it really is essential that as education leaders, we understand whether or not our whole school approach is effective. And for us to understand how do we know this? What does this look like? And that's where there's lots of options. But the first thing, and first and foremost, is that we've got a designated senior mental health lead that's been trained effectively. This is the slide from the DFE that was published in the Green Paper, came out looking at the idea of a senior mental health lead and what they will do. And the Green Paper that was published in December 2017 sort of set out the DFE's plans in terms of the content in that green ellipse that you can see there. And the idea was that all schools and colleges would be encouraged to designate and train a senior mental health lead. And then those individuals would work with staff within schools and colleges who might be in the mental health team, the NHS supported and trained mental health support teams. They'd look at links with CAMS, really looking at how we provide greater links between the services and to look at a preventative approach. And then the blue ellipse around it, the other areas involved, looking at pupils, parents, staff, governance, and then external professionals who might be operating on education setting sites, as it were, links with the RSHE curriculum and links with the inspectors. And we know from an inspection point of view, we see increased reference to mental health. Ofsted, of course, look at it in a number of ways. We've got their new framework. We'll see what that looks like. ISI, those of you under ISI will, of course, know that well-being sits in all four of the judgment areas and safeguarding, really, so all of them in its entirety. So an ever-increasing area of focus and importance when we look at the senior mental health lead training. And there's so many different providers out there. Hopefully, you've got a senior mental health lead who's had training that's been based on the DFE's preferred approach document, which is this one, promoting children and young people's mental health and well-being, the whole school or college approach. And it should be based on those 8 principles, looking at how we promote an effective approach in place. Now, the DFE provided some subsidised training or funded training for state-funded schools. Independent schools had to train it themselves, had to fund it themselves. That funding window is closed now anyway for all education settings. But even though the DFE grant funding period has finished, has closed, it's really essential that you have a senior mental health lead who's trained, who's up to date. And so we would recommend making sure that we continue with that training, that you refresh the training, and that you make sure it's high quality. There's so many different providers out there, and we've worked with so many professionals as senior mental health leads who come to us, who've done other courses and sort of think, this isn't what we thought it would be. But a bit of promotion of Brightcore now. Make sure you have got a highly trained senior mental health lead. When you look at the range out there, it's really important you check out the quality of them. Ours, I'm proud to say, is the highest rated of all the nationally approved, DFE approved senior mental health lead training courses. We got 5 out of 5 in all of their quality assurance standards, and every one of our previous delegates have recommended the course, which is really, really pleasing to hear from. But from our point of view, the testimonials are one thing, but what we want to do is make sure there's high quality information out there, because we care first and foremost about trying to improve provision for children. That's our kind of mission and ethos. So whatever it looks like, make sure that this is an ongoing thing, that you've got a senior mental health lead who's trained, that they've got a deputy perhaps as well. And we look at how we keep this going, because as the data suggests, it's too important to let this slide, as it were, because the DFE funding window closed and all that kind of thing. One of the things that the senior mental health lead will want to do is make sure they've got effective systems in place to identify potential concerns. Now, we need to look at pupils, we need to look at staff, we need to look at members of the community, how they can report their concerns. And there's loads of electronic platforms for pupils to report concerns. And whatever age and phase you've got, I would recommend looking at how we provide systems for young people to report their concerns, to let us know things anonymously if they want to, but of course, as a minimum, without necessarily having to have a face-to-face conversation if they're feeling awkward about it. Now, of course, we want them to have a face-to-face conversation with us, but what we want is young people to tell us when things are concerning them and when they're worried about their friends. So providing digital options, paper-based anonymous options, whatever it may be, is just a key part of that process to encourage communication. And so there's loads out there. We come across the Student Voice, excellent app, regularly with a lot of schools we work with, Toot Toot, Whisper, Sharp System. Those are the electronic ones. There's others out there as well, of course. And then you can have paper-based systems, things I wish my teacher knew, books and boxes, worry boxes, and so on. The key thing is, can young people be confident they can let you know something anonymously, if possible, or if preferred? And then from a staff point of view, I'm sure most of you probably use your electronic safeguarding system for staff to report their concerns. The most commonly used one is CPOMS, followed by My Concern, then Safeguard Everywhere, those kind of things after that. But whatever it looks like, are staff confident using your system to report their concerns? I think is a key question you want to answer. And this is a reporting page. It's a screenshot, a snapshot of a reporting page from CPOMS actually. Now, even if you use CPOMS, yours probably won't look like this, because the advantage of these kind of systems is that they're fully customizable. The disadvantage is also that they're fully customizable, so everyone uses them slightly different ways. But you can see with this particular school, if you just look at mental health and wellbeing concerns, sort of 3/4 of the way down the screen there, the first column of figures is the number of children who've got one of those concerns, and the second column of figures is the number of concerns in total. So you can see in this particular school, there are 114 concerns. 114 children who've got concerns, and they've got roughly 3 each, 314 concerns. Now, this particular school's got about 1,000 children in it, so it's not a million miles away from the national statistics. But why this is useful and why it's important to check these systems is, as education leaders, we can drill down into this data. So if this was the real CPOMS, I could click on that data and I could see, I could click on the mental health and wellbeing tab and I could see which members of staff have reported it. Have they reported a mental health concern linked to safeguarding concerns, or have they spotted mental health concerns on their own? Because remember, that lets us know whether staff are confident around what to spot and how to report them. We can also see whether staff are over-reporting, for example, identifying children who are upset as a mental health concern or well-being and so on, or whether staff are under-reporting. Because it's really important as education leaders that we know the systems are working so that we can identify children early enough. We also get to generate chronologies using these kind of systems. So there's a chronology of a student running from left to right from 8 to over 18 months. And as you can see, if you look at mental health and wellbeing in the middle of the screen there, often we see mental health concerns go hand in hand with a number of other concerns that we identify. So it's really important that we're clear that we've got these links with the safeguarding team. We've got these links that we can make sure we are using to the best of our ability to try and intervene early, because ultimately what we're aiming at is to try and prevent illness where we possibly can. And why this links with safeguarding and why it links with the safeguarding system is when we look at the things like the stress vulnerability model. We know, this is just the University of Cumbria's model of it, but we know that stress is one of the main contributing factors to most forms of mental illness. Not the only factor and not all, of course, but one of the main for most. And we also know that the more we increase a young person or an adult's vulnerability, the less stress we can handle before we reach breaking point. And that's one of the reasons why mental health concerns have always been in keeping children safe as a safeguarding responsibility, because you think about the core job of designated safeguarding needs. First and foremost, it's to protect children and reduce their vulnerabilities. And actually, the more we reduce a child's vulnerabilities, the more stress they can handle. There's actually a mental health benefit to it. So we've got this clear overlap there. And it's really important we recognise the links and we look at what we can do to respond. And we make sure we've got systems in place to help us identify things early, and that staff are using those systems how we want them to. Now, you can have all the reporting and monitoring systems in the world that you want, but they're only really going to play a big part in effective early intervention if we've got 3 other things in place. Now, the first one is, as I've said a couple of times, that your staff have been trained to spot the warning signs, to know how to report their concerns. So that whole staff awareness training is crucial, really. Secondly, that your young people trust your reporting systems to get support for them, their peers, as well as themselves. We know a lot of young people often spot things in each other before the adults do. And then thirdly, that you've got a trained member of staff who responds appropriately to that report. Who's picking up that child? What are they doing about it? Are they a trained mental health first aider? That kind of thing. Do they feel confident in dealing with a young person in distress? So those are 3 other considerations we want to think about as well. We also, from a preventative point of view, want to identify which of our young people are at higher risk. Now, I've only got a few minutes with you tonight, so this is an area we cover extensively as part of the senior mental health lead training. But one area we need to think about first and foremost is children with adverse childhood experiences and trauma. We know those children are one group or 2 groups that are going to be at higher risk. Now, when we look at adverse childhood experiences, we often see the top 10 most common ones are the 3 forms of abuse, the 2 forms of neglect, and then the 5 what we call most significant household challenges. And we know that somewhere between half and 2/3 of children in the UK, or adults in the UK as well, have got at least one of those. The most common one is parental separation and divorce, but mental illness not far behind, and then neglect after that one. And then when we look at trauma, of course, that can be connected to child abuse and safeguarding concerns and so on. But not all trauma is necessarily safeguarding child protection related. So, for example, grief, medical trauma, mental illness, separation from loved ones. When children are experiencing those things, they may not be reported through to the DSLs straight away. And so what we want to do is make sure we've got systems in place where staff are confident around who to report what to, and making sure we're not missing potential concerns or risk factors. Because when we look at the data around children who've experienced trauma nationally, what we see is twice the rate of depression and 3 times the rate of anxiety disorders. So looking at what we can do to support and prevent is an essential part of any effective whole school approach. Just on that note, a useful set of resources, if you're not familiar with it, are on the UK Trauma Council website. I would recommend going and look at their amazing resources, really useful organisation, lots of really good key support resources for you as education providers on there. It's all free as well, grant funded. So yeah, go and have a look at their resources on that note, because I think it's an area we could always do with more support and resources to help the young people in our care. And then the key question for you to think about is, okay, aside from trauma and abuse, who are the other most vulnerable groups that we've got, and what do we do to prevent illness? And as I said, it's a key area that we focus on in designated senior mental health lead training, understanding those vulnerabilities, understanding how to identify and how to respond when children aren't ill necessarily, they're just at higher risk. So what does that look like? And hopefully, if you've had senior mental health leads that have been trained, they've been trained extensively in that, because really any effective whole school approach is a preventative one first and foremost. So that comes with identification. And then we also need to think about the curriculum as part of this before. And I did mention this to some of you last year as well. When we think about the core purpose of a curriculum and schools in general, if we think about what we're in the business of trying to achieve and trying to produce, we're trying to prepare and equip young people for life as independent adults. We're trying to hopefully produce happy, productive, successful young adults at the end of this process. And we're trying to produce positive contributors to society. So as education providers, if we think about that being ultimately our core purpose, we need to think about how young people leave us, whether they leave you aged 8, 11, 14, 16, 21, 25 in some cases. How do you want them to walk out the door on the last day you're responsible for their education? And then we need to work backwards from that point. So, if we look at the NHS data at the moment, currently 1 in 5 school-aged children have got a mental health concern. So it's not a criticism of education settings, but currently 1/5 of children are walking out the door with a mental health concern. So how do we prevent that? How do we focus on this in detail? And don't forget, the DFE's own research showed 12 years ago, the Gutman and Vorhaus report, that if we're thinking about producing successful young people, emotional well-being is a better predictor of success than anything else. Demographics, how much your family makes, the grades you achieve. So absolutely, if we're in the business of producing successful young adults, we need to be focusing on emotional well-being first. So again, any effective whole school approach needs to be looking at the curriculum and strategies in this area. And to quote the often quoted Frederick Douglass, we know it's easier to build strong children than to repair broken adults. So absolutely essential we think about this as part of our core purpose, and not just a sort of bolt on as a bit of PSHE or however else it can sit sometimes. And when we look at how we can increase resilience, this slide was produced by DFE originally as well. So, how can we increase resilience? Well, lots of things we can do. We can do things on the individual level in terms of educating young people around helpful thinking styles, how to self-regulate, how to manage stress, that sort of skills-based approach, so young people understand how to recognize and respond to concerns themselves and prevent, of course. Then in terms of structures within our education settings, helping young people to enjoy school or further education, helping them to engage in physical activities, helping them to find supportive social networks. Really absolutely essential, whether that's within school, but also within those sort of family dynamics as well, and the family units. So We can't necessarily strengthen family relationships, although we can put support in for parents, but actually there's a role we can play as education providers in all of these other areas. And when we look at the sort of three pillars for mental health, healthy diet, healthy amount of exercise, healthy levels of sleep, and we look at those protective factors, social connection and self-regulation, we've got a role to play in educating in a lot of those. So an effective whole school approach needs to incorporate those. We also should look at, I think what's really interesting is when we look at exercise, not just as a preventative factor, but also as a therapeutic input now. You might have seen a study that was published in the British Journal of Sports Medicine 2 years ago now, actually, which was a sort of meta-study that analysed 97 other different studies with over 1,000 trials. And actually, the findings in that study showed that exercise was 1.5 times more effective than psychotherapy or popular medications for reducing symptoms of sadness, anxiety, and distress. So I think it's really important that, again, any effective whole school approach looks at incorporating other departments, not just PSHE, as I said, but also the sports departments and so on. And also, crucially, those departments that promote creativity, because we know, again, looking at protective factors for mental health, creative expression is an essential one. And actually, when we look at those creative departments, they've been massively squeezed over the last, well, 15 years or so, particularly in the state sector. But, you know, I don't know, lots of heads of drama have been made redundant because schools can't keep it on the curriculum. And yet, when you look at the studies into employment characteristics and desirable employment traits, creativity is in the top 10 and has been for the last sort of 10 years or so. Employers want people who can demonstrate creativity. So how do we embrace the creative department, not only in terms of producing those productive, successful young adults, but also as a protective factor for mental health and well-being? How do we help children to find a form of creative expression that they love, that they enjoy, that they want to carry on doing as adults? And, you know, this is nothing new. I know it feels like we're talking about this as a result of COVID more, but the Children's Coalition have been campaigning to prioritise mental health in education for a lot longer than COVID has been around with us. There's an article there in the TES, looking at, well, half a year before COVID, what if we valued well-being more than results? That research from that article from Public Health England, looking at the link between pupil health and well-being and attainment, is over 10 years old. There's an article there from Colin Harries in the TES 2 years before COVID hit. You know, isn't it time we put wellbeing back at the heart of the curriculum? So this is nothing new. It's just COVID and the increasing concerns has led us all to think about this and talk about this more, which I think is a good thing, because actually effective whole school approaches need increased focus. We also know that most mental health problems are preventable, which is good news. Not all of them, but most are. There's also considerable scope for increasing interventions that reduce severity, increase recovery, and so on. So prevention is what we're aiming at here. Now, if we're going to prevent, we need to do it in the school age years, because looking at various different studies, I've mentioned one of them already, we can see that roughly 1 in 5 children have a diagnosable mental illness. Roughly half of mental illness that adults experience is already there by the age of 14, and 3/4 by 18, according to some studies now. So if we are going to prevent, we have to do it in the school age years. Now, if we're going to prevent as well, interestedly, a lot of prevention is about education, not necessarily about clinical intervention, which again is what we do best as education providers. So when we think about preventative whole school approaches, and again, the training should be looking at all of these areas in detail, we've got those 3 strands to it: primary, secondary, and tertiary. Primary prevention is where we educate the whole population. That includes, of course, the curriculum, should include adults as well, to be honest, because most of us as adults haven't had much effective education around understanding how the mind works and how to respond and support ourselves. Secondary prevention is where it sits under keeping children safe in education. Remember that 3rd bullet point of the definition of safeguarding, preventing the impairment of children's mental as well as physical health. So that's where we look at the at-risk groups and we look at what we can do to prevent illness rather than just waiting for symptoms to present. That again should be a key part of the senior mental health lead training. And then tertiary prevention is where you've got young people who are ill or have been ill, and we put things in place to prevent it from worsening or reoccurring. That's where SENCOs come in. In my experience, schools and colleges are all over tertiary prevention. Yes, we could do with more money to support, but actually we know what we're doing when we've got that diagnosis. The biggest area of need nationally, we find as safeguarding and mental health consultants in education, is that secondary prevention. What does that look like when children are at risk, but they're not ill? So again, it's an area we're working extensively to support. So I did just want to spend a moment or two talking about some support resources. I can't go through many. You know, when we do the training, we go through hundreds and hundreds, and there is a lot out there, which is great. It's just not necessarily well promoted to schools and colleges. But I just wanted to talk about some of the tech ones because it's easy to blame technology, and I want to just give some tech some good press, as it were. We know there's lots of digital mental health platforms out there that provide a range of services, from either therapy sessions through video calls, lots of apps that are really useful around sort of computerized CBT. I'll signpost you to some of those on the next slide. We know artificial intelligence can be used to provide an immediate response and an overview and support program. We're seeing that being used more and more. Platforms like Ollie and so on, they're really starting to work in that area quite extensively. We know virtual reality is being used extensively now, and actually virtual reality can be used to create a therapeutic calming support space. So children don't have to go and sit in a waiting room in the town centre in an office with someone they don't know, and all of those kind of things. So that's been used really effectively as well. We know wearable technology like smartwatches, smart rings can be used to track data, to identify and respond to stressors very quickly in a timely manner, but also to gather a lot of sort of metadata to be able to understand and sort of profile illness and various signs and symptoms of concern. And we also know that tech is really helping to destigmatize mental health issues. There's lots of ways that children and young people and adults can be anonymous to get support, and therefore that's encouraging people to seek help, as well as generating more data as a result of it. So, as I said, it's easy to give tech a bad press. Here's some good use of technology from a mental health point of view. The smiling, I'll just go around them clockwise on the screen. The Smiling Mind mindfulness app's a really good one that we come across regularly. The 5 in a sort of C-shaped curved structure on the right-hand side of the screen are all apps from the national charity STEM4, which is led by Dr. Nihara Krause and her team. They're all clinically approved apps focused around CBT strategies to specifically support concerns. So Clear Fear, for example, is an anxiety management app, Calm Harm, reducing the need to self-harm, and so on. So we know there's a lot of positive tech in this space. Tell Me in the middle there is a sort of social media support network for children who've got mental health concerns, where they can connect with other young people. It's heavily regulated, as you can imagine, because of what goes on there, but nothing negative can get posted. But again, really positive. Safe Spot, really good app around coping strategies. Luminova. Luminova is an interesting one. It's the first computer game. So it's an app, but it's the first computer game to have been given MHRA approval because it's clinically proven to reduce anxiety in children, which is great news. So much so that a number of local authorities have bought into it now, so that they sort of buy the app and give it away to their schools for free. So yeah, there's a lot of good tech out there. There's a lot of good signposting online as well. So platforms like the Mix are really great, not only from a mental health point of view, but also signposting from a safeguarding point of view as well. Loads of info on there, phone numbers, chat support, crisis messengers, and so on. So anyone up to the age of 25 can get lots of really, really supportive advice and guidance on there. So yeah, platforms like that are great, and there's loads more. I haven't got time to go through them with you now, but we go through hundreds of options when it comes to the senior mental health lead training and other things that we do. So what can we do as educational leaders overall? I've mentioned a few things. There are other things as well that I would recommend. Firstly and foremost, make sure we improve our knowledge about mental health and well-being, because most of us as education leaders haven't had much training on that area. I think about when I did my teacher training, no one even mentioned the 2 words mental health to me, let alone how to educate, look after my own, lead provision, how to go and do MS for all of that kind of thing. Secondly, I've mentioned this already, but make sure that whole staff training is in place around mental health and well-being, signs, symptoms, reporting concerns, links with behaviour, etc. Really make sure people are confident around what to spot and how to report it. Thirdly, make sure you've got a designated senior mental health lead who's had high quality training out there with knowledge of up-to-date resources. As I said, there's a whole range of courses, some of them not amazing. It's really important that they update their training and they get updated around all the resources that are out there, because they change all the time. We change our course every few months. Fourthly, make sure mental health and wellbeing education is an effective part of your curriculum as part of that preventative approach, not just a bit of a bolt-on few weeks in year 3 or year 10 or whatever it may be. Make sure it's a core part, and your mental health lead and curriculum lead understand how to embed it effectively. Fifthly, make sure you've got that joined up approach. Have those regular scheduled meetings between the safeguarding lead, the senior mental health lead, and the SENCO. thinking about what that secondary prevention looks like. How do we reduce the risk for our young people who are at higher risk when they're not ill yet? Sixthly, make sure you review your whole school or college approach to mental health and wellbeing. Make sure it aligns with your safeguarding one. Look at it internally, look at it externally, get people like us in to review it. It doesn't really matter, but are you reviewing it? Is this working how you need it to be able to produce those productive, successful young adults at the end of this process? And then finally, look after your own well-being as education leaders. I know I talked about this a bit last year, but it's absolutely essential that we prioritize the mental health and well-being of educational leaders. People are leaving this profession faster than ever before, and people are leaving education leadership faster than ever before. And from my point of view, the most important group to prioritize are actually those people leading this provision, because they're the ones that are going to set the direction of travel. So making sure we've got support, we've got supervision in place, and all those kind of things to look after our own well-being as education leaders, absolutely essential. Just finally, if you want any subsidised supported training in terms of things like mental health first aid training as well, we, as part of our mission in terms of what we do, we have heavily subsidised accredited mental health first aid training to support education settings. So we subsidise it by over 50% for individual places, by 2/3 for in-house courses and so on. So we want people to be trained in this area. So it's part of our mission, our remit. So just contact us or go on the website if you want to do that kind of thing at a subsidised rate for training members of staff. Get in touch with us and have a look. Okay, there we go. Whistle Stop Tour and update for this year. I'm going to stop sharing the slides at that point because I'm conscious I've run out of time, but hopefully that was of use to you all and of interest. And Alicia, I'll hand back to you at this point.